This is the agenda of what we're going to be talking about today. I know everyone has stuff to do, so I'm going to try to move through this fairly quickly. So the history of cervical disc arthroplasty, it started back in the 60s, actually. There was a Swedish orthopod whose name was Dr. Fernstrom, who created this or designed this Fernstrom ball for both cervical and lumbar indications. You can see some x-rays of it here. It was implanted through a posterior approach, and mostly due to implant subsidence as well as displacement, it was kind of abandoned, and results were not particularly good. And history of the development kind of sat in waiting until the 80s when this came back, and the Cummins-Bristol disc was what it was called. It was developed at Frenchay in the Bristol in the UK. It was also known as a Frenchay disc. It was a metal-on-metal ball and socket design, and the attempt was to allow range of motion with preventing some of the subsidence concerns that had been brought to light with the ball design earlier. Clinical trials began in the 90s, and they published their initial results in 1996. This was notable for complications with dysphagia and screw pullout, some of which were the dysphagia concerns in particular were attributed to the size of the implant. But this was kind of the advent of what is now the modern cervical disc arthroplasty. And so the rights to this, the Bristol Cummins, was subsequently purchased by Medtronic and became what's known as the Prestige. This was the first FDA IDE trial that began in 2002 with approval for single level given in 2009. Shortly thereafter, or I should say in parallel, the ProDisc, which is a J&J product, received FDA IDE approval in 2007. And then finally, the Bryan disc, which is a little bit of a different design. You can see the ProDisc, I don't have a picture of it up, but it was chromium cobalt plate with porous keels and a ultra high molecular weight polyethylene liner. And then finally, the Bryan disc received FDA approval in 2009. That's a picture of it down below there, which is a significant contrast in terms of the appearance and the design between the Prestige you can see on the right versus the Bryan on the left. And so, in terms of the kinematics and the need or what is expected of these, any cervical disc arthroplasty you put in there, the estimate is that human beings over the course of a lifetime have 100 million flexion extension cycles of the neck. I'm not sure exactly where that calculation comes from, but most cervical disc designs are assumed to require about 30 million flexion extension cycles. And at each spinal disc or vertebral disc unit, the spine as a whole as a unit requires 6 degrees of freedom or motion, flexion extension, as well as lateral bend and axial rotation. And when they've done some studies in terms of looking at segmental rotation and flexion extension with normal movement, you can see that 4 to 7 degrees horizontal rotation at each level, as well as somewhere a fairly wide range of 10 to 60 degrees of flexion extension in the sagittal plane. And part of that, and one of the considerations in terms of the cervical disc design, or when you're trying to recreate those 6 degrees of native freedom of the uninstrumented cervical spine, is the facet joint orientation, which is essentially designed to preferentially allow flexion extension, but that comes at the expense of axial rotation. The orientation of the facets limits that plane. And so when you're considering designing a ball and socket implant, allowing either horizontal, and by that I mean either A to P or left-right translation, this creates a situation where at any given time there is a moment of rotation or an axis of rotation that's kind of dynamic. And if you are not able, if there's a significant mismatch between the instantaneous axis of rotation and the implant's axis of rotation, it creates a shear force that happens at the implant bone interface, which can cause loosening as well as osteolysis. And the other consideration too is that, getting back to that idea of the cervical facet orientation and the fact that that the orientation of the native facet joints can be a block to horizontal rotation at the expense of maintaining flexion extension. Any cervical disc arthroplasty is going to likely place some sort of non-anatomic strain on the facets with rotation and lateral bending. And this is part of the reason why preoperative facet arthropathy is a relative contraindication to proceeding with cervical disc arthroplasty. So, going from that initial Fernstrom ball to the Bristol-Cummins disc, there have been new modifications, or some of the players that are in the market right now that have attempted to overcome some of these challenges, specifically the challenge of allowing that center of rotation, or that instantaneous center of rotation, to change with normal motion of the spine. And so you can see I've got some pictures from the design of some of the current discs that are being used. You can see the Prestige. Hopefully you can see this on the projection, but it's a ball and trough, but the trough is allowing that ball to rotate at different locations based on the A to P translation, hopefully decreasing some of that shear force that I was referencing previously. Similarly, the Secure C has that you can see the spherical interface up on the top, but it also has a dual bearing with the cylindrical interface as well between the bottom plate and the bearing, hoping again to allow for controlled shifting of that center of rotation. Mobi C has a flat bearing surface with the flat sliding bearing surface. You can see the two posts there, and allow for both A to P as well as some degree of horizontal rotation, all being with the same principle in mind of not creating a single fixed point of rotation, because that is not anatomic. Beyond the ball and socket, there's some other players in the market that are non-ball and socket, but instead kind of designing or attempting through a one-piece design to recreate the properties of the native cervical disc. M6 and Freedom are pictured up here. So in terms of getting into the indications and why people are using, or why there's such interest in this, the ACDF is some people, I think it's commonly described as the gold standard in terms of treating cervical degenerative pathology. And part of that is because it's a highly reliable procedure. This is a study that was published in Spine a couple of years ago, looking at outcomes over 10 years of 159 consecutive patients who underwent ACDF at a single institution, looking at VAS, ODI, and the patient's assessment of procedural success. You can see at 10 years, the procedure reported success on the patient side was 85 to 95%. However, 10% did require early surgery for pseudoarthrosis, and at 10 years, 21% had undergone revision for ASD. And you can see that the relationship between that graph down at the bottom is demonstrating time on the x-axis, and then the percentage of patients who underwent adjacent segment surgery. So while ACDF is a reliable surgery, it's not without its flaws. And this is a kind of landmark paper that I think is applicable in this situation, kind of commenting more on the ASD. This is the Hillbrand paper looking at 374 patients, 409 fused levels, followed out to 21 years. And the incidence for the first 10 years was symptomatic ASD, and we'll touch on the definitions piece of this later. It was about 2.9% per year, with ASD rate at 10-year time point being about 1 in 4. Interestingly, the study found that multi-level ACDF had a lower ASD risk than a single-level procedure, and they identified pre-existing degenerative change at the adjacent level, as well as fusion involving C5 or C6 as being specific risk factors for the development of ASD in the setting of an ACDF. So the current indications, because this went through the FDA IDE process, our indications in the United States are based on the constraints or the indications, and this inclusion criteria is actually from the original Prestige FDA IDE, and you can see it's essentially boils down to skeleton mature greater than 8 years, degenerative cervical radiculopathy plus or minus myelopathy from the C3 to C7, and 1 to 2 levels. And that list at the bottom, I believe, is inclusive at this point in time of the implants that are FDA approved for 2-level procedures here in the United States. And so contraindications here, this is again from the IDE, but also just kind of pulling at different sources. Local systemic infection, ligamentous instability, a metal allergy, severe facet arthropathy, as well as ligamentous instability. Now you can see it gets into the gray area with some room for debate or indications on mild to moderate facet arthropathy, both at the index level, as well as the presence of degenerative change, either at the index level or the adjacent level. But those, that list of absolute contraindications seems to be pretty universal. And this was, I thought this was an interesting study in terms of looking at the applicability or the utility of this relatively new technology. It was done in 2007, and it was done based on the fact that lumbar disc arthroplasty at that time, the indications for it were so limited. Surgeons were kind of looking and saying, hey, like, great, you've got the cervical disc arthroplasty, but am I actually going to be able to employ it for degenerative changes? And so this study was published in Spine Journal. It was 166 patients who underwent degenerative cervical procedures, both in a private practice as well as in an academic setting. And they looked strictly at the IDE trials, clinical indications, and found that 43% of the patients that underwent surgery met inclusion criteria, i.e. they could have undergone a cervical disc arthroplasty at the time that this paper was published. So the contraindications or the indications, while they're fairly strict, they are applicable to a significant number of patients. And so as I was preparing for this, in my mind, you kind of look at the questions that came up as I was preparing this talk were, how does it prepare in terms of patient outcomes to ACDF, which is, as I already mentioned, a very reliable solution to the and kind of the workhorse of degenerative cervical change. But also, more importantly, the benefit of changing over to this relatively new technology is, does cervical disc arthroplasty reduce the risk of adjacent segment disease compared to ACDF? And I'll get into some of the studies I looked at, but I'm hopefully give some answers to this. So this was a study that was actually, I retracted is the strong word, but they kind of backed it off. It was published initially in Spine in 2013. It was a Cochrane database review. And one of the reasons it was kind of backed off was that it was based on 2-year data, but it was 9 studies, 2,400 patients. And you can see the primary and secondary outcomes listed there, most of the similar themes throughout many of the studies I'm going to be presenting, because these are the criteria that were used to demonstrate non-inferiority in the IDE trials: neck pain, VAS, patient satisfaction, patient outcomes, as well as neurologic complications. And I highlighted some of the take-home points that a relevant difference was not seen for primary outcomes, although there may be some trend towards some superiority in certain of these outcomes for arthroplasty. But I think the key point from this study, and one of the reasons why it was subsequently backed off, is that final bullet, essentially highlighting the fact that looking at 2-year outcomes for this procedure when you're really examining not only patient outcomes, but more importantly, the development of adjacent segment degeneration or change. Tough to assess that at 2 years. So looking at more, this is now single level ProDisc. This was published in 2020, so a couple of years ago, looking at the 10-year outcomes, single center, 27 patients, 123 months. Some highlights from this, I think, this 74% of patients develop some degree of HO, and I'll touch on this when we get into the complication section later. And 3 patients, 11%, required revision surgery. 2 underwent a CDA at an adjacent level, and 1 underwent a laminoplasty. And this is Prestige as well, looking at the follow-up of IDA, comparative study looking at NDI. And these are the outcomes that they looked at: neurostatus, disc height, need for additional surgeries, and adverse events. And at the 10-year time point, you could see 10% had undergone revision surgery at index level, 13 at adjacent level, and 9% had developed class 4 heterotopic ossification, which again, I'll get to later. But that essentially boils down to bridging bone or complete loss of range of motion on a dynamic x-rays at the 10-year time point. Looking at MoBC, the other, this is now getting into 2 levels. I apologize, that last study was also looking at that as well. 80% overall follow-up at 7 years. This was published in 2017, about 600 patients. You can see the breakdown in terms of the procedures done. And look at the outcome that they really looked at, rather than radiographic degeneration or the presence of ASD on x-rays, was adjacent subsequent surgery either at the index or the adjacent level. And you could see those numbers there, that there's statistically significant reduction in both adjacent level surgery at both the single as well as 2 levels. And so their conclusions on this study was clinical superiority at 2 level and non-inferiority of single level TDR versus ACDF. Now, in terms of what they were basing those claims on, it was based on NDI, the relative improvements in neck disability index in the investigational cohort, as well as the decreased incidence of neurologic failure, as well as subsequent surgery. And it's worth noting that comparing these two, there was no difference in the VAS neck or arm pain scores between the groups. And similarly, looking at 7 years, again, looking at the Prestige, this showed that there was some angular range of motion maintained at the superior and inferior levels versus what would typically be seen in an ACDF with a fused level, where you'd expect that there's some compensatory range of motion above and below the implant. And they found, again, NDI overall success and neurologic success, as well as non-inferiority to neck and arm pain, with significantly fewer procedures at the index level. So these are single data points or single studies, I should say, at various time points, now getting out to mid to long term follow-up, 7 and 10 years, trying to pool these data. There have been some systematic reviews, but limited mostly to the fact that the data that has been or the majority of the data is more at the short to mid-term range follow-up. This was one that attempted to look a little bit longer, with limited their review to greater than 4-year follow-up. And they kind of came to a similar conclusion as what I was just discussing with those other previous studies, which is that cervical disc arthroplasty is superior in terms of success at NDI. But they also did comment on there seems to be a trend towards reduction of adjacent segment. And this is another meta-analysis. I'm trying to move through this as we're coming close on time, but again, published in 2018, and their meta-analysis looked at short to medium-term follow-up, so up to 7 years. And they found that there was significant improvement in NDI, SDF-36, dysphagia, and satisfaction. as well as less adjacent segment disease, which is kind of the big question, both between 2 years as well as between 4 and 7 years. So short and long-term follow-up seems to indicate that the question, that second question that was on there about adjacent segment, may be improved, or should say reduced. Now, what does that mean in terms of ASD? Adjacent segment degeneration, again, it's thought to be brought on by the fact that there's decreased motion at a fused segment, and the compensatory motion required at the adjacent segments may lead to accelerated risk of degeneration. Part of the reason why answering this question in terms of does the cervical disc arthroplasty reduce the incidence of adjacent segment disease or degeneration is terminology or definition, where it seems in general, most studies, or what I can see, is that degeneration is a radiographic finding versus disease is symptomatic or something clinical that may or may not require subsequent intervention. So I had already published, I already shown this, but just to highlight it again, the Prestige implant at 7 years, cumulative rates of index surgery requiring revision, lower, statistically significant, as well as adjacent levels. You can see it's roughly about a half to a third rate at that time point. And looking at this is published in Core, looking at, again, 2 to 7 years, nothing beyond that, but trying to find out, rather than looking at ASD, but using the rate of reoperation, both at the index as well as adjacent levels, as a marker for the development of adjacent segment disease, meaning clinically significant requiring intervention. Overall, fewer secondary surgeries, both at the index as well as adjacent level, based on this meta-analysis that was published in Core. And this table, I thought, again, looking at that, using secondary surgery is kind of a marker for the presence of, or the development of ASD. You can see that in general, the NDI, as well as arm pain, arm pain and neck pain, some equivocation, but secondary surgery in a lot of these studies, both single level as well as multi-level with these implants, seems to indicate that there is a lower rate of secondary surgery, at least out to the 7 to 10 year time point, comparing ACDF versus cervical disc arthroplasty. So it sounds great. What's the problem? Well, one of the problems I already mentioned, based on what was published before, was development of heterotopic ossification, at least with the early implants and earlier studies. This is a complication that is commonly seen, or was commonly seen. This is a grading system from modified McAfee, looking at how to classify the degree of heterotopic ossification. And while 2/3 of the patients in this series had some degree of HO, only 10% had some sort of motion restriction. You can see 3 of them 5-level, and more commonly at multi-level. And going beyond that to another meta-analysis looking at the prevalence of any HO, 53% at 5 to 10 years, based on this meta-analysis, looking at 38 studies. But severe HO, defined as grades 3 and higher, closer to 47% at 5 to 10 years. So looking and taking this heterotopic ossification, as well as some additional outcomes that were referenced or compared in those IDE studies. It's an AO spine study in the Global Spine Journal that attempted to look at do a meta-analysis looking at safety and efficacy of total disc arthroplasty, comparing it to ACDF. In addition to HO, looked at dysphagia, death, secondary surgeries, and neurologic injuries. And you can see that generally did quite well, maybe some slight favoring and wound-related complications for ACDF, but surgical-related neurologic events, maybe more significantly, secondary surgeries seem to favor cervical disc arthroplasty. And so their conclusions were that these results is as safe and may result in fewer secondary surgeries. So not, it seemed, again, may result, but trends seem to be, that statement seems to be my summation of what I found from looking for this. In addition to the risk of HO, in orthopedics, everybody's familiar with the idea that anytime you have an articulating arthroplasty, there's a risk of bearing surface wear and subsequent development of particulate debris. And those implant designs I was going over before looked at, some of them are metal on poly, some of them are metal on metal, but this study looked at, it was published in Core in 2014, and based on some retrievals that had been done or subsequent revision surgeries, they looked at the appearance of the tissue or the generation of particulate wear in the immediate vicinity of the implant. And more or less, what they found was similar to what you see with other arthroplasties. Metal on metal generates a lymphocytic response, and metal on poly generates a more inflammatory macrophage-driven response. But is it clinically significant? Probably not. Very few incidents of catastrophic failure related to these wear characteristics. This one here is a case report. While I don't think you guys can read that, but it says there was 4 cases, but only one of them was a cervical implant. And those notes on the left there are what were found when they looked at the appearance of the tissue after this failure. Essentially, the patient had a 5/6 cervical disc arthroplasty and began developing myelopathic symptoms, and had an MRI as well as a myelogram done subsequently that showed some sort of a mass in the vicinity. And so they went back and revised the implant and found it to be well fixed. They didn't find any significant metallosis in the tissues, as well as there wasn't a significant wear of the bearing surface. But these chronic inflammatory and lymphocyte macrophage appearance is what would be expected from any sort of a metallosis tissue reaction. Osteolysis is a case reportable event, 1 in the ProDisc and 2 in the Prestige. So again, I think that is, to me, I kind of take that as there is some particulate debris generated, which is almost a requirement anytime you have a metal on metal or metal on poly articulation. But to this point, the rate of there being a clinically significant wear that requires subsequent surgical intervention is low enough to the point where it's a case reportable event. And so I know I'm getting near the end here. FDA approval, as I alluded to, is based on, the current indications are based on the IDE and fairly limited indications. But early adopter countries or other countries outside the US have been a little bit more aggressive in terms of going beyond 2 levels. This is a study out of Korea. You can see that this published on 71 discs, 52 patients, but a couple of them 3-level. I think that the breakdown on this is important, and this is why I put this in the kind of next steps, is that when the studies that are published in terms of looking at patient outcomes for multi-level are very heavily weighted towards 2 levels, or the majority of the patients have had 2-level arthroplasty. And so it makes it difficult to, based on those numbers, draw any conclusions regarding the safety or efficacy for greater than 2 levels, which is already an FDA approved intervention for those implants I've referenced previously. And then I think just another indication or kind of reason for our next steps or directions for research or investigation is that what is known about these implants to this point is based on the data that's been taken out from the patients in the initial FDA ID trials, and definitions of success. And more importantly, the definitions of success, one of the key components that they looked at, and the reason you keep seeing it pop up on all these slides, is the incidence of adjacent, either index or adjacent level reoperation, not necessarily the incidence of adjacent segment disease or degeneration. And so the idea is that research needs to be adopted rather than looking at not just at the incidence of surgery and the need for clinical intervention or addressing degenerative change, but does this from a radiographic standpoint actually reduce the incidence of adjacent segment degeneration or disease, which it seems like the jury is still out on that, but trends generally seem to be suggesting that it may. So in take-home or conclusions, it's a high, you're comparing this against a highly reliable procedure that has a history of good outcomes. And so the bar is for this, for a cervical disc arthroplasty to demonstrate efficacy or benefit is quite high. That being said, every procedure has a complication, and adjacent segment disease, pseudoarthrosis are known complications. And a cervical disc out to 10 years, it seems to indicate, particularly with, single levels, there's been a fair amount of research that seems to indicate that the patient outcomes in terms of neck disability index, as well as patient satisfaction, ODI and VAS for arm and neck are at least equivocal to ACDF. And there is also looking at the limited studies that have looked specifically at ASD, as well as the more extensive list of studies that have looked at the reoperation rates at index as well as adjacent levels. There seemed to be some indication that the cervical disc arthroplasty may be able to deliver on its the reason for its creation, essentially decrease risk or decrease likelihood of clinically significant degeneration adjacent to the treated level. That being said, it does come with its own complication profile. And while the particulate debris and metallosis concerns that we've seen from other arthroplasties in the body seem to not be of clinical significance right now, the rate of heterotopic ossification, particularly in the early studies with the earlier implants, is quite high, and something to bear in mind when you're doing your own risk-benefit calculations and counseling your patients.
Well, thank you, Micah. It was a very informative and a good review. It was very nice. One question that comes to your mind, and you pointed out that the decisions as far as whether it's a radiographic, degenerative changes or symptomatic, seems to be this gray area that often falls to the judgment of how the patient gives the history and how the surgeon interprets the symptoms and the history. So what is an ideal patient that reading all of this, that comes to your office and let's just do one level, for instance. Is it age? It is the degree of degenerative changes? Is it level of disease? What would lead you towards decision for arthroplasty in the cervical spine?
Yeah, I think that the general indications that were listed before in terms of C3 to C7, failed 6 to 8 weeks of conservative treatment, cervical radiculopathy plus or minus myelopathy. I think based on what I am taking away for what is known based on my review of this, I think this is one where I would just have a conversation with the patient and really emphasize to them that this is a relatively new technology that seems to deliver on or be maybe heading. The indications are that it may be able to reduce the likelihood of a known complication from the quote unquote gold standard, but we don't have long-term data on it. And I think that it kind of falls back more on the patient, which is, I realize, a bit of a punt answer, but I think that it really is more of a some people, I think, are say, hey, I'm willing to take the tried and true intervention that has a better track record, and I'm willing to accept the known 2.9% per year risk of adjacent segment disease, versus some other people may say, I'm I'm willing to take the risk in the absence of a solid answer to that question based on the preliminary data that's out there. So in summary, I think it's a conversation that you have with the patient, but ultimately I would be more inclined to leave it up to them.
So if you were the patient, and just pressing you a little bit more, and what would be the ideal situation where you would say, I'm going to have disc arthroplasty? What should you have to bring that decision if you were the patient?
Radiculopathy or myelopathy, C3 to C7, failed conservative treatment. I think that it's funny, like Malone asked me this question early on in the year, and I'm a bit of a late adapter. So me personally, I would probably I would take the risk of the adjacent segment disease, and I would be more inclined to go for an ACDF.
Yeah, and it's Dr. Akbarnia. It's interesting for me as a neurosurgeon. I don't have.
Oh, you're on. So you take over.
I had a Samoan speaking patient and a consent issue this morning, but anyways, I was able to catch at least the last half. And I think for me, somebody that's from neurosurgery, I don't have the historical context of arthroplasty. Like a lot of orthopedic surgeons have in relation to their hips and knees and shoulders, etc. And so it's actually been really helpful for me to just hear Micah talk about some of the challenges, and especially in terms of long-term failure, that orthopedic surgeons have faced with other forms of arthroplasty. And that, I think, was an important thing for me to hear. So I think, Mike is right. And I think he's got good reason to be more conservative. Certainly the data, some of the randomized controlled trials, there's one that just came out of, I think, Sweden, which didn't demonstrate significant differences in terms of adjacent segment disease at 10 years. Of course, like any study, any randomized controlled trial from Europe, there are certain barriers to generalizability to an American cohort, probably the arthroplasty they were using in particular. So, this is something that I think we're going to continue to debate for a while. And we're at that Basis Summit meeting this weekend, and a lot of the sort of thought leaders in this space are certainly still debating the pros and cons. So I think anybody that places a fair number of these knows that they work, and they work well. But we have to, leave space to acknowledge that we don't know what's going to happen in 15 and 20 years. And it's important to communicate that to patients as well.
Sounds good.
Yeah. I would say that the hard part is not convincing a patient that they need an artificial disc. Essentially, every single patient wants an artificial disc.
Yeah.
The hard thing is convincing patients who aren't good candidates, whether it's facet spondylosis or loss of lordosis or just age, etc. Yeah. That's the hard part. And, I've certainly a number of patients that want artificial discs, and I just don't think they're good candidates, and they'll go somewhere else. And I think you just gotta hold the line with your indications and what the data tells us for now.
Sounds good. Excellent presentation.
Thank you.
Good job, Micah.
Thanks.
Thank you.